All right, so I'm assuming that you guys did the video and the quiz, right? So that I can start in by assuming that you know what I mean when I say autonomic nervous system. Okay, you know that I'm talking about part of the CNS or PNS, right? And am I talking about efferent or afferent when I'm talking about autonomic nervous system? Efferent nervous system. Is it voluntary or involuntary? Involuntary, okay. So we're going to start with that. And what we are going to do is, so this is the figure that you guys were working on, only I don't talk about enteric nervous system because I'm not quite sure that I'm convinced that it's a thing. But I have to go research it a little bit more before I put it in my lectures. So what we're going to do is we're going to start out where you guys are confident, which is the somatic nervous system, because you know how that works, right? You know the neurotransmitters that are released, yes? You know how, you know the effector, and then we're going to use that to compare it to the autonomic nervous system. Good? So what we're going to do is we're just going to start here with a simplified diagram. So we're going to build it together, and then we'll also fill in the one that's in your notes in just a second. So this entire picture that I'm drawing is going to be the efferent nervous system. Efferent nervous system involves two portions, somatic and autonomic, yes? Yeah? Okay. Somatic, you guys know really well, right? SNS, which is somatic, ANS, which is autonomic. So here's what we're going to do with somatic, and then we're going to compare it. We're going to look at what part of the somatic nervous system starts in the CNS, what part runs through the PNS, what the effector is, and what the effect on the effector is. So this is easy. Okay, ready? So when you are doing the somatic nervous system, the neuron cell body that stimulates your effector is in the central nervous system. It's going to be in the gray matter of the brain or the spinal cord, right? That's where it is. And remind me, and you can see in this figure, on your way from the CNS to the effector, how many synapses do you form? Just one, right? So all you have is a myelinated axon that runs all the way to the effector. Yes? So the only thing that runs through the PNS is a myelinated axon. There's no ganglia on the way or anything, okay? What's the effector for the somatic nervous system, guys? What is it? I didn't hear it. Skeletal muscle, yes. Okay, so it's skeletal muscle, okay? Okay, and what's the effect? Excitation, inhibition, or I don't know. It's always excitation, isn't it? Yes? Doesn't mean you always get a contraction, but it means you're always going the right direction for a contraction. Yes? Okay, so we're going to use this as a starting point because the autonomic nervous system is slightly more complicated. It's not too bad, though. It initially seems bad, but then it clarifies. So what we have with the anatomical route, so here we are in your notes at C. The anatomical route from the CNS to skeletal muscle is simple. So let's make sure that you guys are comfortable with the terminology. The only thing difficult about this set of notes is vocabulary. That's it, okay? So the somatic motor neuron, you guys cool with that? Cell body is in the CNS, in the brain or the spinal cord. The axon goes through the PNS, basically as part of a nerve, yeah? And it synapses with skeletal muscle at a neuromuscular junction, yes? And you know, no ganglia on the way, yeah? Now, some people ask every once in a while, what about the dorsal root ganglion? Does the dorsal root ganglion part of this story? Why not?
Part of afferent.
Yeah, it's part of afferent. It's part of sensory. Yes, good. Okay. Okay. So no ganglia on the way. And you know one more piece of information. What neurotransmitter is always released here? Acetylcholine. Good. Okay. So only one synapse always releases acetylcholine. Yes. The effect is always excitatory, and it'll contract if threshold is reached. It's not always reached. And you guys remember this? The mechanism of excitation is generally to open what kind of channels? Sodium, and cause what kind of polarization? Depolarization. And these synapses are what ergic? Cholinergic. Got it? Okay, use that as our comparison because we're going to start autonomic in just a second. Okay, so autonomic nervous system is a little different. So I want you to understand this part before we get into the details. The autonomic nervous system generally has what we call dual innervation, meaning that for a single effector, you're going to have two hookups. This one, notice we had one hookup and either we stimulate it or we leave it the hell alone. With the autonomic nervous system, here's what I want you to picture. The heart has two dual innervation. Think of it as gas and brakes, yes? Because you can take your foot off the brakes, but maybe that's not fast enough. Then you can actively stimulate it, yes? So it has dual innervation. It has sympathetic innervation and parasympathetic innervation to almost all of your autonomic effector organs. So that's what we're going to see next. So the autonomic nervous system is also called the involuntary nervous system or visceral motor nervous system. And they are always going to go to the same three effectors. What are the three effectors for the autonomic nervous system? Cardiac muscle, smooth muscle, and gland. So here's what I'm going to do here. We're going to simplify this. And we are going to go, let's say sympathetic is here. Parasympathetic is here. And we're going to divide this. And we are going to go to the same effector, because I have dual innervation. Are you guys with me? Okay, so I'm going to end up with a sympathetic hookup and a parasympathetic hookup to this same cell. Okay, all right, so here's the pattern, the anatomical route that you are going to use to get there with dual innervation. So we're going to do this anatomical route and we'll come back and fill in the other stuff after you sort of got the picture down in your head. The anatomical route is a bit more complicated. We are going to have one neuron that starts in the CNS, synapse with another neuron. That second neuron goes to the effector. Okay, so watch. Sympathetic and parasympathetic both start out the same way. Neuron cell body in the central nervous system, yes? Okay. Then it's going to synapse in a ganglion. With the sympathetic nervous system, guys, it's going to synapse in a ganglion very close to the first one because I have a really short preganglionic axon. And I have this one. And then I'm going to go to the effector. Okay? When you have neuron cell bodies outside of the central nervous system, they're in little blobs called what? Ganglia, yeah. So this is a ganglion. Okay? This one's going to have a similar pattern, okay? It is going to have the first neuron in the central nervous system, the second neuron in the peripheral nervous system, only it's going to have a much longer preganglionic axon, so the ganglion's going to be in a different place. Okay, this is also a ganglion. So, do you see dual innervation here? Single innervation there? Okay, so the effect we will figure out in just a minute here. So let me tell you a couple things before we fill in details. Do you see that now what we're going to have instead of just one neurotransmitter and just one effect, yes, we're going to have a neurotransmitter here and here, affects both places. Neurotransmitter here and affects both places. Yes? Do you see? Okay, we'll fill those in just a second. We've just sort of got the basics of the anatomy down for just a second. Okay, so let's go back and make sure that we understand this whole idea here of dual innervation. Go ahead.
Is that a type of convergence? Like you have two?
No, because you would have to have two going to the same one to be convergence. This is just two in series. Just two in series. Okay, so most autonomic effector organs, yes, meaning cardiac muscle, smooth muscle, and glands. I just drew cardiac muscle here because smooth muscle doesn't look like much, and I don't know how to draw a gland, blob of cells. So most of them are dually innervated, so two synapses form on a single tissue. Conceptually, a logic question for you. Does it make sense to you that before I even tell you these two cannot release the same neurotransmitter on the same tissue and cause two different impacts? They can't, right? They're going to have to release two different neurotransmitters if they go to the same tissue and cause two different things to occur. Does that make sense to you? Okay, so we understand that already. We just have to figure out which neurotransmitters. So the effects, guys, on the tissue can be either excitatory or inhibitory, but the effect is more related to what than the neurotransmitter? Yeah, it's related to what the receptor does, right? So if it binds to and opens a sodium channel, it's going to be excitatory, but if it binds to and opens a potassium channel, it's going to be inhibitory. Good? Okay, so the sympathetic division, of course, is quite often called the fight or flight division, right? But you use it during fight or flight and exercise, yes? And so what it's going to do is it's going to change the activity of the tissue for fight or flight or exercise. The parasympathetic division is often called feed or breed or rest and digest. But here's a really common misconception that I would like for us all to get rid of today so that we have a better understanding of physiology. Really common misconception. A lot of people are in the habit of thinking that the sympathetic nervous system is going to excite all of your tissues, and the parasympathetic is going to inhibit all of your tissues, all of the effector organs. But that is not true, because what you really need to do is, with the sympathetic nervous system, it only needs to increase the activity of any tissue that could help you with a tiger, right? Everything else should just chill the hell out for a little while, because I have resource allocation needs and a finite amount of resources. Does that make sense to you? So I have a finite amount of blood, I have a finite amount of oxygen, a finite amount of nutrients, a tiger's in the room. Do I really want to send a whole bunch of blood and oxygen to the wall of my uterus? No, I don't, right? It's not going to help me. As a matter of fact, if I could get it out and throw it at the tiger so the rest of me could survive, I would totally do it, right? So what we need to do is we need to understand that the prediction is not that the sympathetic increases everything. The sympathetic increases anything that would help, right? And it decreases everything that wouldn't help in that situation. So basically, it's resource allocation in this stressful situation. So the dual innervation allows for you to do two different things to the same tissue. So the parasympathetic division activates feed or breed, not stressed out responses of the same tissues. And they generally work opposite one another. Like if the sympathetic increases a tissue, the parasympathetic will decrease it. If the sympathetic decreases a tissue, the parasympathetic will increase it. Okay, so they kind of oppose one another. So the route that we've got right here, let's just look at it and see if this correlates to what we just drew. Also, let's look here too. Okay, so what we will see is that the ANS, the autonomic nervous system anatomical route from the CNS to the effector, is a little more complicated than the sympathetic nervous system. It has a ganglion, it has two synapses, right? The cell body of this one is in the central nervous system. Are you guys comfortable calling this one the preganglionic and this one the postganglionic? Yeah? Because you can look at them and tell which direction the information is going. So this is the preganglionic, and this one's postganglionic. Okay, so the cell body of neuron 1, preganglionic, is in the central nervous system. The axon goes to the ganglion. The cell body of neuron 2 is in the peripheral nervous system in a ganglion and goes to the effector. That was a quiz question that a lot of you guys got wrong. I want you to go back and fix it. Okay, you've got until 10 o'clock tonight to redo or to fix anything about that. So the neuron that stimulates, for instance, cardiac muscle contraction, its cell body is in the CNS or the PNS. It's in the PNS, yeah? Okay. It's not in the CNS. The one that's in the CNS does not actually directly talk to the effector. Okay, so go back and look at that one. You've got until 10 tonight to fix it. I left that up there so that you, in case something didn't make sense, you can go back and look at it. Okay, the cell body of neuron 2 is in the ganglion, which is in the peripheral nervous system, and the axon goes to the effector. So now let's start getting into the neurotransmitters. Okay, you ready? Okay, so the neurotransmitters that are released are not too bad. The neurotransmitters released at autonomic neurons, so stick with me. The neurotransmitter released here and here is acetylcholine. Acetylcholine. Okay, now I want you to see a pattern. Do you see that the entire efferent nervous system releases acetylcholine first, even if there's not a second? Do you see? 1, 2, 3, yeah? Okay. And acetylcholine here, guys, it's always excitatory to the postganglionic cell, meaning that we're not going to stop the message when we haven't gotten it all the way through, okay? So now I can tell you 2 things are true. The entire efferent nervous system releases acetylcholine first, and when it's released first, it is always excitatory. Yes? Got it? Okay. So the message never stops right here. Okay? All right, so back to your notes. The preganglionic neurons of both ANS divisions, sympathetic and parasympathetic, will release acetylcholine. Acetylcholine binds to nicotinic cholinergic receptors on the postganglionic neuron, and it's always excitatory to the postganglionic neuron, and the mechanism is just what you think it would be. The mechanism is generally to open what kind of channels? Sodium, and cause what kind of polarization? Depolarization. These synapses, all 3 of these are what ergic? Cholinergic. Okay, so now of course it's going to have to differ, right? It has to differ right there. It's definitely going to have to differ right there. Okay, the postganglionic neurons in the parasympathetic nervous system are going to release acetylcholine again. Okay? And there it's going to bind to muscarinic cholinergic receptors. That synapse is still cholinergic, okay? And I'll tell you what it does in just a second. The postganglionic neurons in the sympathetic division can't release acetylcholine. They are going to release norepinephrine and also a little bit of epinephrine, which is okay because you already associated that with sympathetic activity, didn't you? Norepinephrine and epinephrine. So the sympathetic division released norepinephrine, and by the way, the ratio as a neurotransmitter is 4:1 norepi to epi. As a hormone, it's 4:1 epi to norepi. So this synapse is what ergic? Adrenergic. Good. Okay, now let's bring this back around and talk about some figuring out how do we figure out what it does? Okay. So is norepi going to be excitatory or inhibitory? Is acetylcholine going to be excitatory or inhibitory to the effector? It depends on the effector, right? So this is what you memorize, but here what you have to do is you have to think about resource allocation, right? So does norepinephrine actually excite or inhibit cardiac muscle? We'll just think about whether it would help if a tiger is in the room, right? What do you think norepinephrine does to cardiac muscle? It excites it, right? But what do you think it does to the smooth muscle in the wall of my uterus? It inhibits it, yes? And why? The neurotransmitter is the same, but what's different? The receptor is going to be different, yes? So when you get here, you don't do memorization, you do logic, you think through resource allocation. And we're going to practice that in just a second, okay? So the effects of either postganglionic neurotransmitter can be either excitatory or inhibitory on the effector organ, depending on the receptor. Yes, depending on the receptor. Good? Okay. So let me give you just a little anatomy review, and then we'll go through that table that's in your notes. So what I am telling you guys with the whole dual innervation idea is that your heart has 2 hookups. Your uterus has 2 hookups. Let's do the heart. Everybody's familiar with the heart. So you've seen this picture before in anatomy, right? Some anatomy professors don't teach autonomic nervous system. So if you haven't seen it, it looks crazy when you first look at it, but it's not really that bad. So what you're seeing is 2 different nervous system hookups. I'm not implying that this person has 2 different brains and spinal cords, right? 2 different nervous system hookups, okay? Did you know, I was just thinking about something funny. You know those Wireman models in the lab? apparently, like, there are entire semesters in which a person goes through and thinks that you have arteries on one side and veins on the other. So I thought it might be necessary to tell you that this person does not have 2 brains and 2 spinal cords, because assumptions. Okay, so here's the deal. Here's what's happening with you right now. I know, I didn't know. I was like, do you really think that the artery, it goes down your right arm and comes back? Like, how the hell would that work? I don't even understand. But it just makes you realize that, like, teaching is like fleshing out misconceptions a lot more than you thought it was. Okay, so here's what's going on with you right now. Mike looks pretty chill right now, okay? I would imagine that his parasympathetic nervous system is probably controlling his heart activity right now. So what I want you to understand is how the anatomical route goes, right? The anatomical route to chill his heart out below what it could be doing, right, is going from, look on this side, parasympathetic, right? It's going from the medulla oblongata. You guys knew that the medulla oblongata gets to control heart rate, right? And it's going out a cranial nerve that you should know. Which cranial nerve controls heart rate parasympathetic? Cranial nerve, heart rate, parasympathetic, 10, which is the vagus nerve. Okay, follow the vagus. You knew that, didn't you? Yeah? You're like, you just asked it the wrong way. Okay, cranial nerve number 10 is going to go out, right, from here. And it's going to go to the heart. Hey, I've got a heart here. It's going to go to my heart, because I'm a nerd and I wear nerd necklaces. Okay, it's going to go to my heart, and it's going to release which neurotransmitter? Acetylcholine. And acetylcholine is really putting the brakes on what my heart can do, okay? So now a tiger walks into the room. First thing that happens is take your foot off the brake, not fast enough. So what do you need to do? You need to put your foot on the gas. Here's how you do that. You're going to go, instead of out cranial nerve number 10, medulla oblongata is going to send the signal down the thoracic region of the spinal cord and up nerves that go to my heart, yes? And it's going to release which neurotransmitter? Norepinephrine. And what's it going to do? Increase your heart rate. Yeah? That's the dual innervation that we're talking about. Yes? Okay? Understand the sort of anatomical, physiological sort of overlap? All right, so now, before we get into the whole resource allocation prediction portion, let's just make sure that you guys can do this figure that's in your notes. Okay, so I found this figure. It's from a different textbook, but I think it's so fantastic because it puts everything sort of in context. All right, so the comparison of the autonomic and somatic motor systems. What I want to do is fill in all the blanks that are in here. Okay, so this one is going to skeletal muscle. So which branch of the efferent nervous system is this? That's the somatic. Okay, notice that it correlates exactly to what we're doing, only it's just drawn better. Okay, and neuron cell body in the CNS, this runs through the peripheral nervous system to release what neurotransmitter, guys? Acetylcholine. The effector organ is skeletal muscle, right? And the effect is what? Excitation or inhibition? Excitation, okay? So let's do these two, okay? This branch of the nervous system goes to cardiac muscle, smooth muscle, and glands. So which branch of the nervous system is in yellow here? Autonomic, okay? And then it's composed of the parasympathetic and the sympathetic, okay? I'm going to tell you guys about this one in just a second. I haven't told you about it yet. So let's look at this top picture. The sympathetic nervous system, of course, has its first neuron in the central nervous system going to a ganglion and releasing what neurotransmitter right there? Acetylcholine, okay? And then it is going to go to the effector and release what neurotransmitter? Norepi as a neurotransmitter, epi as a hormone. Okay, good. Okay, I haven't told you this yet. I'll tell you that in just a second. Let's do the parasympathetic really quickly. Okay, parasympathetic nervous system, right? Preganglionic releases acetylcholine. The postganglionic releases what? Acetylcholine again. So now we just need to go back and make the connection between the sympathetic nervous system and the endocrine system. You've already done it, but let's just reinforce it with what we're doing here. The autonomic nervous system or the sympathetic nervous system actually controls, of course, the adrenal medulla, yeah? Okay, so what we are going to have is the sympathetic preganglionic neuron will release a neurotransmitter, which we now know is acetylcholine. You guys with me? Okay. The postganglionic one is a modified anaxonic neuron. So it releases a neurotransmitter-like chemical, but it releases it into a capillary bed, so it ends up behaving as a hormone, right? But doesn't this look like a neuron without an axon? Yeah? So what it does is it releases epi, more epi than norepi, and dumps it, instead of releasing it at a synapse, it dumps it into the bloodstream. Somebody remind me why. Why is this advantageous to, for instance, involve the endocrine system instead of just doing repeated nervous system release of the neurotransmitter norepinephrine? What does this do for you? Longer lasting, that's one of the advantages. More widespread, yes. Yeah, because it can like have metabolic effects that we don't have if we don't release it this way, right? And then one other thing, isn't it cheaper to release it as a neurotransmitter than to repeatedly have action potentials and release it as cheaper to release it as a hormone than to have repeated action potentials and release as a neurotransmitter, right? So this is getting involved and you dump it into the bloodstream. Yeah? Does that make sense? This is the only exception to the 2 neuron chain thing, because this last one doesn't really act like a neuron anymore, right? It really kind of acts like it's a glandular cell or something. It's actually modified from a neuron, FYI, though. Okay, that's sort of the only exception. So that's the same thing that we were looking at right here. Does this make sense now? Okay, you release acetylcholine, and then this one dumps epi and norepi into the bloodstream. Yeah? Is that okay? Go ahead.
Would that be because it's longer stress periods?
Yeah, so sometimes, like, if you can't get away from the tiger in a minute, right? Then what happens is you're like, hey, this is going to take a little while. Let's dump some into the bloodstream. And usually it's released either with a stress that lasts a little longer than an immediate acute stress, or a stress that's more extreme. Yeah? So like if somebody walks around the corner and startles you, you probably don't dump this. But if your car does donuts on the ice, you probably are going to dump this. Right? Does that make sense? Scott, you have a confused look on your face. What's your question?
I'm going back to this picture.
Okay.
I wrote, on the parasympathetic, I wrote, that's what you know about me. That's acetylcholine.
It's acetylcholine.
Okay. Can't remember why you said that.
Why I said acetylcholine?
Or why is it acetylcholine.
Oh, these two have to release 2 different neurotransmitters right here to cause 2 different effects. The rest of the whole damn story is acetylcholine except one place, right? Okay, so this is acetylcholine. This one is acetylcholine here because both preganglionic ones release acetylcholine. And then this one has to do something different or else you can't cause a different response. So I think you might have just written it down wrong. Go ahead.
When does then the CRH trigger, like in one instance would just the hypothalamus say, tell the adrenal medulla to release E and NE versus...
The hypothalamus doesn't.
I mean, because isn't it the CRH to...
That's cortisol. That's adrenal cortex.
Okay.
That's not directly
So
related to
NE
the story.
never released through, yeah. Okay.
Yeah, that's not, I mean, it's related to the stress story, but it's not related to the epi story. Yeah?
Okay.
That's chronic
So
stress.
this is how always
Yeah,
hormonal is released.
Yeah.
Okay.
Yeah.
That makes
Yeah.
sense.
Got it? Okay, so everybody good with this figure? Because this figure will probably show up on a test with different things blinked out, right? But I think it's a really good synthesis. Everything's nice and organized in there, right? Okay, so what we are going to do now is we're going to figure out the end part. Like, how do you predict the effect, right? Okay, and my objective, just a second, with going through this table that we're about to do will be to dispel the misconception that the sympathetic excites everything and the parasympathetic inhibits everything. What was your question?
So they do work at the same time if you are in chronic conditions?
Usually they're not going to be working like simultaneously, but they might be passing off from one to the other. So like Tiger walks in, what I'm going to be doing is simultaneously decreasing parasympathetic stimulation while I increase sympathetic stimulation. Yeah, so it's not like one has to be completely off for the other one to be on, but generally speaking, it's kind of a handoff, right? When they're doing one versus the other. Is that okay?
Yeah.
Does that address
Because you
your
won't
question?
shock the stomach if you are eating something.
No, right. So usually it's like a little handoff, and it's actually 2 different pathways in your in your nervous system, so they don't have to one be off before the other one turns on. Usually what happens is you're slowing this one down and increasing that one at the same time. Good? Okay, so here we go. One more time. I did this already, but I want to make sure that the terminology does not impede the understanding. So check your understanding of the autonomic nervous system before we go any further. If I say autonomic, one more time, is it afferent or efferent? Is it CNS or PNS? It's PNS. Is it voluntary or involuntary? It's involuntary. It's involuntary in every way imaginable. It doesn't even map to your cerebral cortex. And nothing that doesn't map to your cerebral cortex can be voluntary, right? It maps to older portions of your brain like your hypothalamus, your medulla oblongata, and your pons. So it's not even like related to or connected to consciousness. This is way older than consciousness. And of course, you guys know it has two divisions, sympathetic and parasympathetic, which control fight or flight and feed or breed. My phys professor said that the autonomic nervous system controls the 4 Fs. Fight, flight, feed, and breed. You won't forget, will you? Okay? One of my other classes did not get that at all. I'm like, that's all right. You don't have to get it. Okay. So sample activities. So here's what we're going to do as we go through this. We are going to look at an organ, at a tissue within that organ. It has to be one of the 3 effector tissues. Yes? What are they? Glands, cardiac muscle, and smooth muscle. Okay? So that has to go there every freaking time. And then here's what we're going to do. Instead of me telling you, I'm going to try to get you guys to tell me your logic so that it reinforces the logic that you've got. We're going to try to figure out what the fight or flight nervous system will do to the organ. And I'm going to say, hey, why does it make sense that you would want to dilate your pupil in fight or flight conditions, right? And then we'll figure out whether that represents excitation or inhibition. And then we'll look at what the parasympathetic nervous system does. Okay, so let's do the first one together, and then I'll start asking you guys for help as we go through. Okay, with the eye, what the autonomic nervous system can do, among other things, is control the diameter of the pupil. Yes, control the diameter of the pupil. What tissue is that going to be of the 3? Smooth muscle. Yeah, it has to be smooth muscle. Got it. Okay. The sympathetic nervous system, see if this logic makes sense to you, or somebody explain it actually instead of me. The sympathetic nervous system will cause pupil dilation. Somebody explain why that would be worth the money when a tiger's in the room. So you can see better. More light in, right? See better. Okay? So that makes sense to you? Pupil dilation? Okay. So in order to understand whether that represents excitation or inhibition, I just have to show you a little bit of the anatomy. So the pupil is, of course, a hole. Yeah? Okay? And the way the muscles are arranged around, the smooth muscle cells are arranged around the hole is kind of like this. Now, with smooth muscle, you don't usually talk about origins and insertions, but let me just give you that. Okay, so now tell me how I can get this hole to be wider. Do I excite this and contract it, or inhibit it and relax it? Excite it, yank all open the hole, right? So because of that anatomy, pupil dilation represents excitation, not inhibition. Does that make sense? Okay. And parasympathetic nervous system. The parasympathetic nervous system constricts the pupil back down to its normal size, right? And same anatomy. Does that represent excitation or inhibition? Inhibition. Yeah? Okay. So it inhibits it. Does anybody remember which cranial nerve controls parasympathetic pupil constriction? You two. 3, yes. She's got it. Yes, cranial nerve number 3, the oculomotor nerve. Good. Okay. All right. Next one, salivary gland. What kind of tissue? A gland, yeah. It's right there in the name. The sympathetic nervous system, does it make sense to you that the sympathetic nervous system decreases salivary gland secretion? Why? Explain it. Somebody explain. What? Yeah, not important, not worth the money. I always think about it this way. If a tiger eats you, he can digest your Egg McMuffin for his damn self, right? Okay? You do not need to do salivary gland secretion to help him along, Okay, so sympathetic nervous system decreases secretion. This, of course, we run into in situations. Have you ever like had a really bad job interview and it's like not going well at all, and your like mouth is all dried up? You're like, not only am I sweating, pit sweat down to here, can't remember a damn thing, pupils are dilated, heart rate, and like can't get the tongue off the top of my mouth. You're like, this is terrible. So salivary gland decreases secretion, and that represents inhibition. Parasympathetic nervous system increases secretion of salivary gland, and that represents excitation. Okay, the lungs, specifically not the lungs, it's the bronchioles leading to the lungs, bronchioles, okay? And you're going to control the diameter of the bronchioles. What kind of tissue? Smooth muscle. Now, does it make sense to you? And if it does, explain it. Somebody who doesn't usually talk, please. Okay? I want you to get involved in the process. Somebody explain why the sympathetic nervous system would want to dilate your bronchioles. Yeah, allow more air, more oxygen in. Yes? Okay. Now, in order to understand whether that represents excitation or inhibition, I have to show you that anatomy. And if we do a cross-section of the bronchiole and look at how the smooth muscle is arranged, it's not arranged like that. It's arranged like this. Okay? So if I stimulate these, is it going to constrict or dilate the bronchioles? Constrict. So what do I need to do? I need to inhibit and dilate, right? Does that make sense? Okay? Got it? So I don't want to contract these because that would actually constrict the bronchioles. So what I need to do is inhibit these and allow for relaxation and dilation. Okay? The parasympathetic nervous system will constrict them back down to normal levels. Now, if you guys are thinking about about allergic responses, remember allergic responses are paracrine. We're talking about nervous system activity here, right? Okay? So are you starting to see that in your column, the sympathetic nervous system does not excite everything? Yes? It excites some things and inhibits other things? Okay. So next one, this one should be easy. Heart. What's the tissue? Cardiac muscle. Okay. And the sympathetic increases heart rate. I know that you know, but tell me why. Why? Yeah, more blood, more oxygen, more stuff. Tigers. Damn, tigers. Does that represent excitation or inhibition? Excitation, good. And the parasympathetic nervous system decreases the rate. Okay, and that represents inhibition, good. All right, stomach and intestines are going to do two different things. Stomach and intestines do motility, which is what kind of tissue? Smooth muscle. And secretion, which is glands. Good, so we're going to have two. Okay? All right. Somebody explain to me why the sympathetic nervous system would want to decrease motility and secretion of the smooth muscle, of the digestive tract. Sympathetic nervous system decreases motility and secretion of the digestive tract. Yeah, you can't really afford it. You've got different places that your resources need to go. So it actually does tend to shut down your guts for a little while. Interestingly, what happens right after is as soon as it turns on, it turns your guts right back on, and you might crap yourself. Definitely does. Have you ever seen that with ambulances? Yeah. Turn it off, turn it back on, piss yourself, crap yourself. That's a messy job, huh? Yeah. I don't know why you guys want to take care of living people. With dead people, I know exactly what to expect all the time. I'm like, this is going to be like kind of formaldehyde-y, and definitely don't poke the bowel. Everything else is fine. Decreases motility and secretion. Does that represent excitation or inhibition? Inhibition. And then parasympathetic increases motility and secretion. Okay, now this is where it gets different, and I want you to listen because this is important for the next set of notes as well. Okay, so I have arteries and arterioles that are supplying tissues in different places in the body, right? Do we have just comparable blood flow to every place in the body at every time? No, we don't. We have differential blood flow based on the body's needs, yeah? Okay. And the body's needs for blood flow are going to be pretty dramatically different in some places with sympathetic stimulation, okay? So what we are going to do is to control the diameter of arteries and arterioles, supplying two different places, right? And this is not the only two places. I just chose two extremes so that you could sort of see what's going to happen. I'm going to have arteries that are supplying your skin and your viscera, meaning abdominopelvic cavity, right? And then I'm going to have arteries that are supplying your skeletal muscles. And they're going to respond differently to sympathetic stimulation. Either way, those two are going to have the same anatomical setup, and it's going to be very similar to how bronchioles are, okay? So before we go any further, if you are controlling the diameter of arteries and arterioles, what kind of tissue are you dealing with? Yeah, smooth muscle, of course. We're going to be dealing with smooth muscle. And what we're going to do is we're going to be dealing with the same tissue, and we're going to be releasing the same neurotransmitter, but we're going to cause two different things to occur because they probably have different receptors. Exactly. So here's what's going to happen. See if you can make this make sense to you. The arteries that are supplying your skin and your viscera upon sympathetic stimulation, tiger coming in the room, those are going to constrict. Somebody make that make sense to me. Sympathetic stimulation, arteries supplying your skin and your guts are going to constrict. So it's really differential blood flow, right? Where do you want the blood to go? Do you want it in your skin? No. Do you want it in your viscera? No. Where do you want it to go? Comparatively, you really want it to go to your skeletal muscles, yeah? Heart, lungs, brain. That's it. Everything else can suck it. Okay? So, does that make sense? So what is going to happen is the arteries supplying your skin and your viscera will constrict. Now, the impact is that generally does raise your blood pressure, yeah? Of course, your heart rate's also increasing, which will raise your blood pressure. The reason it raises your blood pressure is that you tend to, in that situation, do vasoconstriction more places than you do vasodilation. So the net effect is that you just basically increased constriction in the tubes collectively. Okay, so not all tubes. So arteries supplying the skin and the viscera are going to constrict. That raises your blood pressure. The anatomy is like this. So how do you cause constriction? Do you excite or inhibit? Excite. Yeah. Okay. You excite and it causes constriction. Okay. That means that the receptors that are on the blood vessels leading to your skin and your viscera respond to norepinephrine with depolarization and excitation because they have receptors that do that. Okay. Now, this is important for now. It's also important for later. Vessels anywhere in your body have no parasympathetic innervation. Here is how you do sympathetic versus not sympathetic with the nervous system. With vessels, you always have some baseline sympathetic stimulation that gives you tone. When there's a tiger in the room, you have more sympathetic stimulation. When there's no tiger, you have less sympathetic stimulation. There's no parasympathetic innervation. So this is like the exception to the sympathetic parasympathetic rule. Okay, all right, so now let's talk about the other one. Arteries supplying skeletal muscle, same tissue, same neurotransmitter, yeah? Sympathetic stimulation will cause dilation. And does that represent excitation or inhibition? Same anatomy. It's inhibition, yeah? So the only difference is that there's different receptors there. So with more sympathetic stimulation, they just open up more, yeah, and send more blood flow to your skeletal muscles, yes? Because of different receptors. And the same thing is also true. They have no parasympathetic innervation. How do you allow for those to constrict? You just do less sympathetic innervation, right? More sympathetic on those will cause them to open up. Less sympathetic will cause them to shut down. So what's happening right now in you guys is less sympathetic stimulation to your skeletal muscles because you don't need a disproportionate amount of blood to go to them right now. Tiger walks in the room, more sympathetic stimulation, more dilation. Yeah? Okay. So, by the way, this correlates to what happens when you get freaked out. Anybody ever notice what happens to your skin when you get really freaked out? White first. Now, if you start to heat up, it'll send blood right back to it. But initially, with a shock, you're like, oh, and all the blood goes away from your skin, right? Why? Because you sent it elsewhere, really. It's just like resource allocation. Does that make sense? Okay. So, last one we already did, but let's just reinforce it. The adrenal medulla is also stimulated by the sympathetic nervous system. What tissue is that? Gland, yeah. Okay. And what this one does is it secretes epinephrine and norepinephrine into the bloodstream. Does that represent excitation or inhibition? Excitation. There's no parasympathetic innervation of the adrenal medulla. You just don't stimulate it when you're not freaked out. Good? Okay, so let me give you guys a couple of questions to think about and show you how important it is to understand the terminology, the vocabulary. Okay, so you ready for a couple of questions? What is the effect of parasympathetic postganglionic acetylcholine on cardiac muscle? And your choices are excitation or inhibition. Question again. What is the effect of parasympathetic postganglionic acetylcholine on cardiac muscle? Inhibition, right? Do you see that there's a whole hell of a lot of words in there, right? But it's a relatively simple question, isn't it? Okay. What is the effect of parasympathetic postganglionic acetylcholine on the smooth muscle of the digestive tract? Excitation. What is the effect of sympathetic postganglionic norepinephrine on salivary gland secretion? Inhibition. What is the effect of sympathetic preganglionic acetylcholine? Excitation. Yeah? Okay. Got it? Okay, so really the set of notes is relatively simple as long as you've got the vocabulary down. Yeah? It's not outrageously complicated. It's not definitely not like endocrine level of complicated. Let's be serious. Okay, questions? No? Really? For reals? No? Okay, go ahead.
You said that parasympathetic for something in the intestine was excitation, right?
Parasympathetic postganglionic acetylcholine excitation. Yeah, because the parasympathetic nervous system, feeder breed, would excite the digestive tract. Yeah?
And like the you get tiger and things like calm down so that
No, that would be like right now. What's going on? If you ate breakfast, what's going on right now? Parasympathetic is in control, digestive tract, yeah? And what it's doing is exciting your digestive tract. By the way, this has to do with the story that your mom always told you about not going swimming right after you eat. And what's that all about? How's this related to this story? Yeah, and as usual, mom was like right-ish, right? She was like not wrong, but not right? What happens is when right after you eat, of course, your parasympathetic nervous system is really sending a whole bunch of blood flow and a whole bunch, and this kind of has to do with her question that she asked before too, or one of you guys, whole bunch of blood flow and a whole bunch of muscular contraction in your digestive tract, but then you jump in the water, right, and you activate your sympathetic nervous system, right? But what you have is you have competing blood flow interests. And if you're still sending it all to your guts, you don't send enough to your skeletal muscle, and your skeletal muscle cramps up. So she wasn't wrong, right? Yeah, go ahead.
that's why you don't eat a big gigantic breakfast before you go work out because
Oh, yeah, right. Big gigantic.
you're eating, so you're
Yeah, you're competing. At least you won't drown, though.
you want to
I eat those like sugar packs, those like just straight glucose.
Yeah, straight.
When you're doing that running, like marathons and stuff.
Yeah, that's what they do when they're running, and they don't really need for much digestive
Yeah.
activity. But anyway, so mom wasn't all the way wrong. She rarely is all the way wrong. Okay, so next set of notes is cardiovascular. Oh, I haven't told you guys this yet. So cardiovascular system, a couple of things. First, we're moving your test from Tuesday to Thursday, so you'll have a little bit more time for, it was supposed to be a week from today. It's going to be a week from Thursday instead. She's like, what the hell are you talking about? So, like, test, do we have tests? So it's going to cover the same material, and we'll probably finish it on Thursday or at least the beginning of Tuesday. I just want you to have a little bit more time for absorption. So, yeah. And then I'm going to post a video for you guys today or tomorrow just showing you how to read this thing. You don't have to use it if you want to. Have you guys ever used a concept map or a mind map before? Have you ever used one? Okay, so the cardiovascular system is really logical but really complicated. And you can have both, right? like a whole bunch of little logical relationships that are all relatively complicated. So I made this for me, and I will show it to you guys, and you definitely don't have to use it if you don't like this kind of thing. But if you want to use it, I'm going to post like a little 20-minute how to use this kind of thing. So this is called a mind map or a concept map. And this is all of the cardiovascular system stuff that we're going to talk about. It's the same stuff that's in your notes. It's the same stuff. But I'm not going to post it without telling you how to read it. So if you want to use it, you can. And once I show it to you, it'll actually probably click. You'll be like, oh, red will decrease. Green will increase. Those both impact blood flow, right? Okay, so I'm going to post a little 20-minute video showing you how to read it. I will also post this for you in a PDF. And if you want to manipulate it and make it even better, which Sarah probably will, and she's going to hand it back to me, it's going to be way better than the one that I made because she does that. So then I will post the actual editable file for you. It uses a program called MindNode. And MindNode is free for Mac stuff. I don't even know if it's available for other stuff yet. I use the Pro, and that's not free. Pro you can put stuff into. Anyway, so I'll post that for you. If you don't like it, then just don't use it. I don't care. It's just that like all of it is kind of related, and it's nice to be able to like look at it and see all the relationships. Okay, so one last thing, and then we'll start getting into it. If you are not good at heart anatomy, get good at it. It's logical. You need to remember what the circuits do, systemic versus pulmonary circuit. You need to know the names of all the chambers. You need to know the names of all the valves. You need to know what the aorta is connected to and what the pulmonary trunk is connected to. If that anatomy is rusty for you, then please go brush it off, either with your anatomy book or your text or your physiology book or with interactive physiology, because I'm going to assume that you know that anatomy. Cool? And luckily, cardiovascular anatomy kind of sticks with people. It's not like most things. Okay, so we are going to start with Roman numeral 2, and we're going to start to look at the physiological design of the cardiovascular system. Of course, design is in quotes because it wasn't designed, it was actually evolved. But so the big picture of the cardiovascular system is that the cardiovascular system is just fancy plumbing. That's all it is. It's an interaction between pressure and resistance to allow for flow, right? So here's your big picture understanding. The overall trump functionality of the cardiovascular system is to ensure adequate blood flow to capillary beds. That's really what it's supposed to do. Everything else is just fancy plumbing to get there, ensure adequate blood flow to capillary beds. Because if you didn't ensure adequate blood flow to capillary beds, you would die anyway, right? So that's why counterintuitive things can occur. So for instance, let's just think about this. Let's think about hypertension for just a second. So with most forms of hypertension, what happens is you have eaten In-N-Out Burger 3 times a week and not exercised for the last 15 years. And you got all kinds of gunk on the insides of your blood vessels, right? And what that does is, of course, increase your pressure because the tubes are smaller. Yes? Everybody with me? Okay. And although it seems counterintuitive, what your heart does to kind of try to compensate for that is increase heart rate, which of course increases your blood pressure further, which seems counterintuitive until you realize that that is the function that you're actually trying to serve, right? So when you got atherosclerosis, you compromised adequate blood flow to capillary bed. And so what you did is you increased your heart rate to try to ensure adequate blood flow to capillary beds. Even though, of course, it increases your pressure and it's bad for the system over time, yes? But you were going to die today if you didn't ensure adequate blood flow to capillary beds instead of in 5 years, right? Does that make sense? So this function wins against everything else, always, okay? All right, so let's talk about what blood flow does. Blood moves via flow like any other fluid. Flow is due to pressure, right? So you are going to get flow of blood or any other fluid produced by pressure. And of course, the pressure is created by what? What creates the pressure? Huh? No, that's adding to the pressure that you've already created. Where did you generate the pressure? Yeah, the pumping of the heart, right? So the pressure is created by the pumping of the heart. You can augment the pressure by constriction or dilation of the tubes. You can also augment the pressure by increasing or decreasing the amount of fluid. Yeah? Does that make sense? So you have a pump, yeah? And then you can change the tubes or change the volume of the fluid. Those are the ways that you can manipulate pressure. So blood moves due to bulk flow produced by pressure, created by the pumping of the heart. And what we want is unidirectional flow of blood through a circuit. And the way that we do that is to have a pressure gradient, yes? High pressure in the left ventricle, slightly lower in the aorta, still lower in the arteries, lower still in the capillaries, all the way back to 0 millimeters of mercury in the right atrium. So as long as we have a pressure gradient, then you have unidirectional flow of blood. If, for instance, I had massive constriction or a blockage in the inferior vena cava, then I can actually cause pressure to go backwards, right? I cause the blood flow to go backwards. That's not the best day that you have. So what I need is a pressure gradient. Okay, so you guys predict for me. What do you think? As pressure increases, flow tends to do what? Increase, yes? Now, is there such a thing as too high a pressure? You know there is. Pressure gets too high, you break the whole damn system. But generally speaking, as pressure increases, flow increases, okay? But flow is opposed by something that you may not have thought of before. Flow is opposed by what we call resistance. Resistance is occurring in the tubes, and it's any friction that occurs in the tubes will oppose flow. So as resistance increases, flow tends to do what? Decrease, yeah? Okay. Resistance does not really occur to any great degree in the heart because it's pretty wide open, but it does occur in the vessels because they're relatively small. So there's more friction up there. Good? Okay, so now, why are capillaries so important? Well, you know this. All gas and nutrient exchange happens at the capillaries. It doesn't really happen at arteries and veins because they're too thick for gas and nutrient exchange. And so you already know this as well. Almost every cell in the body is within a few centimeters or millimeters of a capillary, and generally, like in systemic circulation, you know that you're bringing in oxygen and nutrients and you're taking away carbon dioxide and waste, and that's nothing new to you. Okay, one last little tidbit before we get into the whole pressure flow and resistance story. Now, if you get oxygen to a tissue, you don't usually have to worry about transporting it because it's lipid soluble and moves straight out of the capillary into the interstitial fluid and then straight out of the interstitial fluid into the cell, right? So you just have to get it near there, and then like diffusion takes care of the rest, right? Same thing with carbon dioxide. Right? Carbon dioxide just moves straight in. So you don't have to worry about transport mechanisms, right? Once you get it in the area, then the whole concentration gradient will take care of itself. So, but FYI, you do move both oxygen and also some other things out of capillaries by filtration as well. And filtration was not based on concentration, it was based on what? Pressure and size, right? So FYI, you always push stuff out of capillaries into interstitial fluids by filtration, but you suck most of it back up by osmosis. Because if you moved a whole bunch of stuff out and then just had concentrated big molecules on the inside of the blood, you just end up sucking a whole bunch of it back up. That's, by the way, why you end up getting turnover of interstitial fluid. You push it out by filtration, you suck it back up by osmosis, push it out by filtration, suck it back up by osmosis. And so you move things back in. Okay, so now let's get into the story that we want to tell with the rest of today. So we are going to talk about pressure flow and resistance. And to me, this is really logical, and I really, really like logic puzzles, so hopefully it will be to you as well. If you get confused, ask now, not 15 minutes later, because with the cardiovascular system, every little logical relationship is the thing that you need to understand for the next one, okay? So make sure that you ask if you get confused. Okay, so circulation, the whole blood flow story, is really an interaction between pressure flow and resistance, but we need to learn it in more detail. Okay, so you guys know I don't make you memorize very many equations, but this is one that you do have to memorize, and it's really easy to understand. F, which is flow, is the goal, yes? And F equals delta P over R. This is resistance, this is delta P, which is a difference in pressure between 2 points. So before I kind of implied to you a bit of a fib. I said that as pressure increases, flow increases. That's not actually true. And logically, let me show you why. So this is a tube, and I'm going to have the pressure at point 1 and the pressure at point 2. Yeah? Okay. So it's really the difference in pressure between 2 points that allows for flow, because think about this. If this was 100 millimeters of mercury at point 1, and this was 100, do I get any flow? No, right? And you won't get any flow if you increase it to 200 or 300 or 400 if they're both the same, right? It's really the difference in pressure between 2 points that allows for flow. So let me give you another one. And then you can tell me the direction of flow. So if this is 100 and this is 80, then you immediately know that goes that direction. If this is 100 and this is 80, it goes that direction, right? So the difference in pressure not only tells you the direction, but it also will tell you the speed, because I want you to compare this one to the next one I'm about to write and tell me which one is going to have a faster flow. So this one is 100 versus 80, and this one is 100 versus 20. Which one has faster flow? That one has faster flow than the first one, right? So the difference in pressure between 2 points determines directionality and also velocity or speed of flow, right? Okay, so let's talk about that. So flow is generally measured in some unit of volume versus some unit over some unit of time. You can measure it in liters per minute or milliliters per second or whatever, okay? And its flow is impacted by 2 factors. So let's really explore the pressure one first. So blood flows from high pressure to low pressure. So let's look at that. So look at this figure in just a second. Okay, blood flows from high pressure to low pressure. And pressure is generated, as we said, by cardiac muscle contraction and is also dramatically impacted by vasoconstriction and vasodilation and also the volume of fluid in the system, right? Okay, and it's going to be measured in millimeters of mercury, just like you measure barometric pressure, blood pressure, which is pretty much anything. Okay, so the important thing for you to understand is it is the difference in pressure between 2 points that determines both the direction and the velocity of flow. And in order to reinforce that, let's look at this figure. Okay, so this figure is out of your textbook, and what they did is they changed delta P and watched what happened to flow. And they are keeping the resistance constant at 2. Okay, so look, here's P1, here's P2, right? The delta P is 40 millimeters of mercury. Everybody with me? Okay. And apparently the resistance was 2 because the flow is 20 mils per minute, right? 40 divided by 2. Everybody with me? Please note that in this one, I don't care what your resistance is because you ain't got no delta P and you don't get no flow. Good? But this is important for you guys to think about related to hypertension. Please look at the bottom one and see that you can get exactly the same amount of flow at much higher pressures, right? Because it's really delta P, not P, that matters. So let's look at this one. This is 20 compared to 160. The delta P is still 40 and the flow is still 20. It's exactly the same as this one. But which one is going to be harder on the system over time? A or C? C. It's going to be harder because it's hard for the heart to generate that much pressure. It's going to have to work harder. And the tubes themselves are going to be under higher pressure, right? And how well does your plumbing work if it's under high pressure for long periods of time and was not designed for that? You're going to bust a hole in it, right? So this is what chronic hypertension is. So why the hell would you do this? Because you are trying to serve the flow god, yes? Even if you trash the entire system in the process. Does that make sense? So it's really delta P that matters. And if one of your P's increases, the other one has to increase to compensate for it. Okay? All right, so flow is, now we can say a truer statement. Instead of flow increases as pressure increases, we can say as pressure difference increases, flow increases. Yeah? That's really the deal. Yeah? Because I'm not going to tell you that my father-in-law who has hypertension has better blood flow than I do. He does not. That's not true. Okay, go ahead.
So just to clarify,
Yeah.
So in order for say a person with higher blood pressure or more plaque buildup or whatever,
Yeah. Mhm.
Have the same workflow as me.
Yes.
Or it has to work harder just to have the same
Yes.
amount of pressure.
So
And
here's,
that's why they have higher blood.
yeah. So it starts with one thing. So let's just tell the story sequentially, right? As if it happened one step after the other. What happens is they gunk up their blood vessels and increase their P2. Yeah? Especially in combination with low levels of exercise, because exercise cleans out your blood vessels. But they gunk up their blood vessels and bump up their P2. And then what happens is in order to maintain your blood flow, you have to bump up your P1, which is the pressure generated by your heart, which usually happens by increasing both heart rate, right, and the strength of cardiac muscle contraction if you can. And sometimes if that goes on for long enough, what happens to the size of your heart? It increases in size. You get cardiomyopathy increasing in size, right? It's really hard on the system over time, right? So using your heart that way when you're exercising is acute. Using it this way all the time is chronic. It's really, really hard on the system. Good? Okay. So now, the magnitude of pressure varies throughout systemic and pulmonary circulation. Always assume I'm talking about systemic unless I tell you I'm talking about pulmonary circulation. And so what we need is we always need for to be a pressure differential so that blood will keep flowing. Does that make sense? So if we look at the average pressure throughout the system, note, here's the systemic circuit, here's the pulmonary circuit. So let's look at systemic. The average pressure in arteries is higher than it is in arterioles, and higher than it is in capillaries, and higher than it is in venules, all the way back to the right atrium. So you guys remind me, the systemic circuit goes from what chamber to what chamber? Left ventricle to right atrium. Good. Okay. And it's much higher pressure, but the same kind of story that you have for pulmonary circulation. Pulmonary circulation goes from what chamber to what chamber? Right ventricle to left atrium. Okay. Please note that it's the same kind of story, but a way lower pressure. So 2 questions for you. The first question is, why is this pressure adequate for the job? It's not very far, right? And then the second question is, what anatomical difference accounts for these differences in pressures between the 2 circuits? Something about the heart. Nope. What anatomical difference accounts for those 2 differences? Think about the ventricles. Yeah. Left ventricle is way, way thicker and can generate way more pressure. Okay? All right. So with that in mind, so the other thing is that not only are the pressures higher in the arteries, they're also more variable. So if instead of looking at average pressure, you just looked at systemic circuit and you took more data points, do you see what the pressure does in arteries compared to veins? Do your veins even have any discernible pulse pressure at all? No. What you have in, for instance, your systemic arteries is the pressure is going to be really high right after ventricular contraction and much, much lower right before the next ventricular contraction. And of course, this correlates to taking your blood pressure, and the top number correlates to systolic, which is here, and this is diastolic. Yeah? Okay, so the pressure is more variable and higher in arteries than it is in veins. Yeah, but that makes sense. You guys knew that, right? Okay, so now let's talk. Oh, by the way, one last thing. I'm going to reinforce this several times. Whenever you're talking about manipulating pressure, and you do manipulate pressure quite often because it's one of the easiest ways to manipulate flow. Yeah? Whenever you're talking about manipulating pressure, no matter whether we're doing with drugs or hormones or neurotransmitters or paracrine agents, there's only 3 real dependable ways to manipulate pressure. Do something to your heart, do something to your vessels, do something to your fluid volume. Yeah? That makes sense? Okay. Which one is going to be the slowest way to make a change in pressure? Heart, vessels, or fluid volume? Yeah, fluid volume. You're like, hey, I need to increase my blood pressure. I want to drink something, wait for it to get absorbed, go into my system, and hopefully my kidneys won't pee it out. Or, hey, my blood pressure's too high. I think I need to pee out 3 liters, right? So it's sort of a long-term mechanism for managing blood pressure. Your heart is pretty fast, and your vessels are pretty fast. So let's talk about resistance. Resistance is the one that is usually a little less intuitive for people. Resistance is how difficult it is to flow between point 1 and point 2, holding the pressures constant. So this has to do primarily with what's going on in the tube that will increase or decrease friction. Okay, so peripheral resistance, how difficult it is for blood to flow between 2 points at a constant pressure difference. So we can't change both variables at one time, so we're holding the pressure difference constant, and we're going to change the resistance between the two. So let's predict it just based on this. Flow is inversely proportional to the resistance between 2 points, or as resistance increases, flow does what? Yeah, flow decreases, right? Does that make sense? So the primary determination with resistance is friction. So let's think about the things that could increase friction. So what factors impact friction and therefore impact resistance? The first one, you're not going to see change that much over the course of any day in a person, but it will impact resistance. And this is the viscosity of the fluid. So if instead of pumping something that was about the consistency of whole milk, you increase the viscosity or the thickness of the fluid massively, and you're trying to push something that's the consistency of like maple syrup, then of course, right, you're going to have trouble with flow because the resistance increased. So the thickness of the blood is relatively constant in a healthy individual, but if you get super dehydrated, your viscosity goes up, makes it a little harder to pump your blood. Or if you decide you're going to do blood doping because you're an athlete, what they do is they give their own blood and then shove the red blood cells back in after they've already made it because they're trying to increase oxygen carrying capacity. Or they shoot themselves up with a hormone called erythropoietin to increase red blood cell synthesis. And they can end up having heart attacks and strokes. Why? Because they increase the resistance so much that they compromise the flow. Does that make sense? Okay. So this changes as your hematocrit changes, but it changes with dehydration. But in most of you, you're not really going to like see that big a change. This one we do. If I kept the numbers constant but increased the distance between P1 and P2, then I'm going to have more friction. So it's like trying to blow milk through a tube that's this long versus a tube that's 10 feet long. In order to get flow from point 1 to point 2, I'm going to have to increase pressure or else I'm not going to get the flow, right? So a longer tube gives more friction. And this matters, of course, because if you gain weight, you have more tubes. Yes? And so gaining weight tends to correlate to what blood pressure? Higher, because it has to. It's physics, man. You've got more tubes. You gained 40 pounds. You got 40 more pounds all infused with capillaries that you have to send it through, right? So it tends to, what does your doctor tell you when your blood pressure gets high? First thing they tell you is you probably don't want to lose some weight. Okay, so you increase. Now, of course, it also happens with pregnancy, but this is acute, not chronic, okay? Almost all of us, when we get pregnant, are going to have an increase in blood pressure because of pregnancy. Why? Well, you just gained, golden retriever, you just gained anywhere between 20, and I have a friend who gains 100 pounds every time she gets pregnant, and she's 5'1". Her nose gets ginormous. So it's crazy. I'm like, you really need an IUD more than any person I've ever seen. She's my friend. I can say that to her. Okay. So you gain anywhere between 20 and 100 pounds, and your pressure has to increase because you've got to send it through all of those capillaries, right? Hopefully you are not also super stressed out because that's going to cause vasoconstriction and increase it further. But pregnancy is associated with higher blood pressure, but it usually goes right away as soon as you give birth to the extra poundage. Okay, so that is vessel length. Now, what about gaining muscle mass though? Does that do the same thing? Well, it's interesting because it kind of comes out in the wash because when you do cardiovascular and aerobic exercise and you actually put on muscle mass, what tends to happen is you're training your heart to be more efficient, and you're also cleaning out your blood vessels because you are making the good cholesterol, right, with exercise. So gaining muscle mass doesn't usually correlate to significantly higher blood pressure because you have the balance out changes. Okay, and then the last thing is vessel diameter. And the vessel diameter is basically, generally speaking, if you have a larger tube, you have less resistance and therefore more flow. And if you have a smaller tube, you have more resistance and therefore less flow, right? So let's look at this. This figure is slightly wrong though, and it irritates me. Okay, so this is trying to show you low resistance versus high resistance. But these two are not at the same pressure, are they? B is at a higher pressure than A. So they really needed two figures right next to one another instead of one. So just pretend that they actually drew it right. It bugs me though. Okay, so what they're saying right here is that the delta P is constant, which is not actually in this picture, but A is wider and therefore has less resistance and more flow, and B is narrower, therefore has more resistance, right? And it does have more resistance, it's also higher pressure. So pisses me off. So anyway, smaller tube, more resistance, less flow. That makes sense, right? Aorta compared to the brachial artery, right? Right? Okay, so, but that's just sort of the inherent vessel diameter predisposition, larger tube, less resistance, more flow. Exception, can you get so wide that you won't have any flow? Well, yeah. You can have a little stream, it's got a little flow. You have a big stream, it's got a lot of flow. But then you have a lake, and it's got no flow, right? If you get so big like an aneurysm, right, then you have no flow whatsoever. Like that big abdominal aortic aneurysm in that cadaver on Jordan campus, they just stuff that full of packing material to maintain the pressure. Okay, and then, what?
He's here.
He's here?
Yeah, I don't think he's on Jordan.
Oh, okay, he's here. Okay, I meant here. So one last little thing before you guys leave. You can also change the diameter of a vessel with vasoconstriction and vasodilation. That's regional and short term, right? And if you do that, you're just manipulating resistance to manipulate flow, right? But it's regional. So the diameter of a vessel and therefore the resistance can be changed with regional vasoconstriction and vasodilation. So let's just put this together. If arterioles constrict before a capillary bed, it does what to flow to that organ? Decreases because it increased resistance, yes? And then decreased flow, yes? But if arterioles dilate before a capillary bed, it increases flow to that organ. Why? Because it decreased resistance and therefore it increased flow, right? So that's what you're doing. So last little tidbit is, although viscosity, vessel length, and vessel radius all impact resistance, only one of these do we manipulate over the course of the day to try to impact flow. Which one? Which one? Do we impact vessel length or viscosity? No. The only one that we really manipulate is diameter, right? That's the one that we manipulate, okay? The other two change over long periods of time, but they don't change daily. Okay, so next time we're going to start on cardiac muscle tissue, and I'm going to post the concept map for you and just a little video to show you how it works. Yes?
How does vessel length change weight loss?
Yeah, the vessels will actually atrophy when you lose weight.
Like the muscles in the vessel are going to be.
Eventually, they'll actually shut down if you don't use the tissue at all. Okay. Unfortunately, you don't lose any of the fat cells, so you never really lose all of the vessels, but you can lose a lot of the vessels if you don't have as much fat.
So that would happen like after you lose